Hello, everybody. I welcome you to this AOTK expert meeting about the FNS, Femoral Neck System. My name is Christoph Sommer. I'm a trauma surgeon working in Chur, close to here in Switzerland. And my co-moderator is?
I'm Karl Stoffel. I'm an orthopedic and a trauma surgeon, and I work in Basel.
So we will talk and show you, demonstrate you this femoral neck system. The content of our presentation will be as you see here. So we will talk about the clinical problem and the solution. This is the task of Karl Stoffel. He also will describe the system. Then we will show you some cases, normal cases. Then we do the practical demonstration here, showing you how we insert the femoral neck system. Then we go back to Karl. He will present you the first clinical results we have from a study which is ongoing. And then I will show you some more problematic and cases, also failure case. And then we will sum up everything. And if there are some questions at the end, of course, we can answer your questions. So I hand over now to Karl, who will start with showing the problem.
Thank you very much, Christoph. So let's assume you've got a patient with a Powell's 1 fracture of the middle neck of femur. If you put in the screw center to central, then we have got a nice looking X-ray, but the problem is we have got no medial support, in particular if there is no absolute anatomic reduction at the medial fracture site. So the risk is, if the patient stands on it, that the whole head will collapse into varus until the screw has got some support along the medial calcar. So in these cases, is it advisable that the first screw you put in on the AP view is along the calcar, because that will restore the missing support at this level and prevent a collapse of the head in the varus. On the lateral view, it is important that the second screw is more along the posterior cortex in the neck in order to prevent an extension collapse of the head. So that's fine with Powell's 1 fractures. But if you have got a fracture which is more vertical, like a Powell's 2 or 3 fracture, it's nearly impossible that we can bring the screw that far distally that we have got some medial support. In this case, very often, if the patient loads it in Powell's 2 or 3 fracture, the head will collapse, even if you try to be with the screw very distally. So here a clinical case, a female, 57 years of age. It's a Garden 3, a Powell's 2 to 3 fracture, and you can see the fracture on the right side, and here you can see it marked as well. That's from the early days. Used 2 screws, one as close as possible along the medial calcar, and 1 screw along the posterior cortex on the lateral view. But you see what happened? The whole head just collapsed in the varus until the screw had some support along the medial calcar side. So we've got the problems with those Powell's 2 and 3 fractures that we have got a varus collapse. Sometimes we have got a shortening. Even if the fracture heals, we have got a short leg by maybe 1.5 centimeters, so the patient has got a bad clinical outcome. We've got complications of maybe a non-union using screws, or we've got also some peri-implant fractures. That all has been reported in the literature. So the question is really, if you have got a Powell's 2 or 3 fracture, we need some sort of an angular stable implant. That's available. That's a case here. The patient additionally had also a shaft fracture, which was fixed with this retrograde nail. This fracture has been fixed with the DHS and an anti-rotation screw. So if you look a little bit at the drawback of this system, you need 2 different trays. You need a tray for the DHS and a tray maybe for the canalated screw. So it's quite a technical, complex surgery. We've got quite a large footprint, because even if you use a 2-hole DHS plus the anti-rotation screw, we have got to make quite a big incision laterally and to take off the valgus lateralis. The problem what we've got with these devices, we have got a lateral protrusion, and they can cause some soft tissue irritation on the lateral side, lateral thigh pain. We've got the problem that because you want to place the screw, an anti-rotation screw, very often the main loading implant is not in the central position. So that means we increase the tip apex distance in those cases. And we all know the complication, and also because those 2 implants, they're not connected with each other. They're completely independent. So the problem what we know is we've got the failures like this. So the non-union and the varus collapse, even if you use an angular stable implant. What we've got also is sometimes, especially in the Asia-Pacific region, we've got very narrow canal, and sometimes you don't have the room to place 2 implants, like the DHS anti-rotation screw. And at this stage, the system does not allow any kind of a controlled collapse. This patient, he's got a shortening of maybe 1.5 centimeter, and he lost a complete offset. So this patient, even if the fracture has healed, he will limp and he will be unhappy. And if he's fit enough, most likely requires a total hip replacement or a hemiarthroplasty. So what is the solution to this kind of a problem? So we need something which is easy for intraoperative handling and an easy surgical technique. We need something that has got a small footprint, something which has not a lot of lateral protrusion causing tight pain. We need something we can place in the central head of the head, and additionally something which gives us a rotational stability at the same time. We need a connection between the anti-rotation screw and the main loading implant. If it's too narrow, as I said before, just one implant, and we should be able to control the amount of collapse we want during the surgery. And the solution is, that's the Femoral Neck System. It was launched last year on the 1st of October, and it consists of 3 parts. The first part here is the plate. It's a base plate. It has got a bolt which can slide up and down, and we have got an anti-rotation screw, which is connected angular stable with the bolt. So if you look at the implants, as I said, we've got the base plate, which comes either as a 1 or 2-hole plate. That reduces the amount of the footprint, and it will be fixed with an angular stable screw in the shaft. The angle of this plate can be variable. If you've got a patient with a more varus hip, you can position the plate slightly more in varus because you fix it with an angular stable screw. If it's more a valgus hip, you can adjust also for this different CCD angle. The implant consists of the bolt. That's the main load carrier. It has got a blunt tip in order to prevent a cut through into the hip joint, and it has got a dynamic design. We have got the anti-rotation screw that provides rotation stability. It is locked with the bolt itself, and that allows this combination allows even to put it in a patient with a more narrow canal. So those are the implants: plate, bolt, and screw. There is single packaging with the 1-hole plate and all the 3 components in one single package. So when it comes to the instrument, and that's the beautiful thing as well of this implant, we have got one insertion handle. That's the blue part here. So that serves as the handle for the entire system. We use it to bring in the plate. We use it to bring in the bolt, and it allows also laterally to insert K-wires through the system. We have got the insert, which is also connected to the handle itself, and this insert is used to drill for the anti-rotation screw and also to insert the anti-rotation screw. Everything through one instrument. And we have got the protection sleeve for drilling and insertion of the locking screw in the shaft. So all the 3 steps are guided with one single instrument. The indications at this stage are medial or lateral neck of femur fractures. Contraindications at this stage are pertrochanteric fracture, subtrochanteric fracture, or intratrochanteric fractures.
Yeah, so as we heard, it was launched in last October 2017. So we started using it in November, the first case. This is just one typical case. Up to now, we use this implant for about 20 cases in our hospital. Karl has a little bit a larger experience. This is a typical case, female, 52 years old, with this unstable femoral neck fracture. So it's a Garden 3 fracture. It's displaced, and it's quite vertical fracture line, so it's a Powell 3. And what we usually do is a closed reduction on the traction table, and in most cases, I would say 95%, we are able to reduce the fracture closed. But I think that's the very important first step to have the nice reduction. A little bit over-valgization, that might be okay. So we have to prevent, of course, a varus position. You see also in the axial view a nice alignment in the axial one, which we usually get with maximum internal rotation of the leg, the knee, and the foot in our traction table. Then we start with the first central wire, and you see here the central wire is not perfectly in the center in the axial view, so it can be changed then on, and then insertion of this implant. We will demonstrate you after how this works. This is the intraoperative picture, and now you see here the post-op picture. There's already a little bit of collapse, minimal. It can be measured, I'll show you in other cases. In the axial view, it's not fully central, so not perfect, but anyhow, after 6 weeks, we have the same position, and after 3 months, the patient has hardly any problems anymore. He's walking without crutches. After 6 weeks, usually we allow them to walk without crutches, and that's the 3-month follow-up. The first case we did in our hospital is this type of more stable fracture. So it's a Garden 2 and Powell's 2, maybe also impacted in the axial view, not really angulated. So I think that's ideal to just stabilize this situation with an implant, so not doing any reduction. Of course, leave this in this position. Now you see here the post-op picture, and you see the implant is in the correct position. It's not really a fully center-center. I personally prefer it maybe to have it a little bit further down, but I agree with Karl that it should be in the center-center. And you see here the 7-month follow-up, and we have a 1-year follow-up of this patient. She's pain-free. She doesn't want to have this implant removed, so it will stay in. The last case I show you now in this part of our presentation is this fracture. It's also a 53-year-old male. Bike accidents, very often we see these injuries in the recent time by the mountain biking, downhill biking, and we get these femoral neck fractures quite often. So you see here also Powell's 2 to 3, it's a displaced fracture, and again, close reduction on the fracture table, as you see here. And then the central wire. Now we start with the central wire first. You see maybe it's a little bit caudal, and in the axial view it goes too much anterior. So it can be corrected. Of course, it has to be corrected. Now you see it here. In the AP view, you see the wire is in the center, and in the lateral view, that's the central wire as well. So it's in a good position. We need to have a second wire there to keep the reduction reduced, because when we drill the hole, we have to have some rotational control of the head. So therefore, is a second wire necessary. This can be placed or should be placed outside of the planned insertion of the bole. Usually it's cranially placed, as you see here. So the final picture intraoperatively, and the post-op picture. And after 6 weeks, so starting now full loading after that time, and the 3-month follow-up, I think we can say the fracture is united. It's not, in the axial view, not perfectly aligned, but the patient is doing fine. So that's this case. I think we change now to the demonstration of the insertion of this implant, and so Karl will assist me. We have here already a little bit prepared this femur here, this shin bone femur. We prepared already a wrong drill hole. We will show you, because we want to demonstrate you some special instrument which was developed for this implant. Now, Karl, please give me the aiming jig with the wire in. So the aiming jig is as 130 degrees in there. So you place it here on the fluoroscopic control, of course, and because we already made the drill, the hole, I'm not really drilling, just demonstrating. So we know now on the fluoroscopy the wire is too anterior and a little bit too caudal, too distally. Therefore, you see it's a special instrument developed to correct a malplaced wire. And there are different options available with a 5-degree angle. And now we can use this and put it on here on our wire. And then we are quite flexible. If we can have CT, can we just show up to here where the handle, yeah, maybe you see it here. Now we can think about where do I want to have my new wire. So I want to have my wire more cranially, this position, and posterior. Therefore, I come with a second wire. So, you see, now I use this correction, 5 degrees. I go more posterior and a little bit cranially. So the entry point is 5 millimeters more cranially. Then, of course, we have to check it, take it back. We can remove the first wire. We remove this, and we check it, of course, on the fluoroscopy again. Now you see, now we have here a very nice central position. So, and this can be done, of course, not just once, it can be also done a second time, depending where we really want to have our wire placed. And this instrument works really very nice. We have here another model already prepared with the wire in a central position. So, next step is, of course, we measure the length, as we do it in other implants as well. So I measure here 103. So 103 with the wire, the tip of the wire, just at the cartilage. So 103, then the rule is take 5 millimeter off. So this means 98. And take the next smaller one, which is we have it in 5 millimeters difference. So we use now a 95 implant. So Karl now will demonstrate you how to apply the drill. It's also a
three-step drill?
Three-step drill, as we know from the DHS. So he puts in the 95 millimeters, the length, and he assembles it to the drill machine. Okay. So this usually is done by quite a small incision, maybe 3, 4, 5 centimeters long. That's enough usually in a normal built person. If you have an obese patient, maybe this has to be a bit larger. Usually I do it with 2 Hohmann hooks, one in front, one in the back. You do the same to have the free way to come in with this drill. So now we drill in. Of course, as in other implants, we have to check on the fluoroscopy that my central wire is not advancing into the hip joint. So that's the second step. And now the third has to be just a little bit drilled here at the entrance of our plate to be able to bring this plate close and nicely close to the bone. So I think that's enough. So we go out. We check on the fluoroscopy again if our wire stays in place. Very often the wire comes out, as you see here, so the wire is out. Karl, what to do now? Help me.
So I think it's very important that the wire goes back into the same position. What you can do is you can disassemble here the machine, and then here you can just push this a little bit forward, and then you take it out.
Thanks.
So that means the K wire remains at the tip in the center position where it was. Because that's important, because the K-wire will guide also the insertion of the bolt itself.
Yep. Maybe you have just give me the machine here. I have to little bit to advance it, because maybe it was not fully through. We did intentionally not bring this wire fully through because we didn't want to penetrate the joint for this demonstration. So I go a little bit further. Okay, that's it. So it stays in position.
Okay. Now it comes to the assembly of the instruments. So you see, that's the handle here. That's one handle. That's a second piece, and you insert one piece into the other like this, how it is. Then you take the plate. So the surgeon told me, as a nurse who I am today,
One hole plate.
that he wants a one-hole plate, and the bolt here, that's a 95 millimeter bolt. To assemble it, it comes from the back and then inserts. You see, the plate has got two lateral side drills, the bolt as well. So once the bolt is in, you can't put the bolt in the wrong way. It only can go one way in. And that also prevents the bolt from rotation already. Then what you do is here on the instruments, you can see that you insert the plate from proximally here to distally, and then you attach with this instrument here, tighten on the back, and then you connect now the plate to the handle itself. And that's how you'll get it from the nurse. Okay?
Okay, that's it. So then we bring this bolt and plate over our wire. And usually it's easy just to slide it in, to push it in. Even in reality, usually not much resistance. Now, just for the final pushing in, maybe you see, Karl, we are not fully there with the plate. I can try to hammer it in. Maybe I didn't drill enough. So there is an instrument where you can just slightly hammer it in. Does it go in, Karl?
It goes in a little bit, yeah.
Huh?
Yep.
Are we
2
in
millimeters.
contact? 2 millimeters? I'm not sure if, I mean, this is a plastic bone. This is very hard bone, and maybe we cannot really hammer it in. In real life, usually it's not a problem to bring it down to the base. If it's really, let's say, too hard bone, and you realize you cannot bring it fully in, there are two different options. We could here just bring it drill this little bit back, and then we can push the plate in. So this means we have the 20 millimeters. We have usually we have a dynamization of maximum 20 millimeters. Now it's already minimized a little bit, so we would have maybe only 17 millimeters. But it's very important that the plate is in good contact to the bone. The other option would be just remove it again and drill in a little bit further. So change from to 95 maybe to 98 or something like that, just to make the hole a little bit longer. So after that, we have to check on the fluoroscopy and clinically. I mean, we have some approach, but we cannot see much through our small approach. But on a fluoroscopy, tangential view, if the plate is in good position. Then what can be done wrong is if we angulate this, if I show it here, then the plate is not aligned to the diaphysis. And of course, this has to be, yeah, you can show it like that. So we have to bring this arm of our guide parallel to the femoral shaft. I just bring it back, yeah? This is very important. So, and maybe also with the gravity, maybe it falls a little bit down or can fall down, so we have to keep it in position. But it is easy, so the surgeon can have it in one hand. He can look from the lateral view to the diaphysis, align it to the diaphysis, and as soon as he's happy, he comes with the drill of the anti-rotational screw.
Just one trick, maybe. If you don't want to hold it always in the handle, there's a slot here on the instrument, here, where you can use to insert the KY, just here, to hold it in place. And you can just go anywhere into the bone.
Yeah, but not in the wrong position, huh? Okay, take your fingers off.
That's okay.
Okay. That's a good trick. Thanks, Karl. I've never used. Oh, yes, I used.
Then you take it
Good.
out.
So next step would be to take out this central wire before we come with our anti-rotational screw drill.
So the anti-rotation screw drill again, what you do is, can you see here the numbers from the top? Probably have to come closer. So again, what you say, it's the same length as the bolt. So we have reamed 95, and that's what we do here again.
You can see it here.
Sorry. So we go to 95. Can you see? 95. Okay. So that's the same. That's a 4.3 drill bit. That's the same drill bit as we use also for the locking screw in the shaft. Okay.
Yep. Okay. Oh, it's not attached here. Yeah, that's better. Now I can feel there's good bone in there. Good. Take it out. So if we didn't have this wire here, of course we have to keep this in position. That's important. So you bring it, okay, with the machine. That's allowed.
Mm-hmm. That at the end.
So final tightening, of course, has to be done manually with a torque limiting attachment, as usually 4 Newton meters. Okay. So now everything is quite stable, but still, if we would rotate this, the neck, the head would rotate with our inserted bolt and anti-rotational screw. So we still have to keep it in position. But now, Karl, with your trick, maybe it's not working, so I have to remove it. Okay. The next and last step is to insert this locking screw through the same aiming device. We put this in. We use the same drill as we heard already, 4.3. Here I can measure, together with fluoroscopy, I can measure the length as soon as I'm out here. Maybe I go a bit back. I could measure here. It's 48, huh? So I go out.
Or you could also use.
I could measure it with that. Okay. So it's 42. Here it's only 42. So give me 44. So it's a bicortical screw position. I think that's important. So we have to remove that, isn't it? It goes through here. No. Mm-hmm. Yeah. Okay. Final tightening by hand. Okay. Now the last thing maybe we can show you is if someone would like now to compress the fracture, that's an option. There's a special instrument here. This is applied into the anti-rotational screw. There is a thread in there. It goes into the anti-rotational screw. So it's tightened here. And now turning on this black wheel here, I can pull the bolt together with the anti-rotational screw backwards. Of course, we should not tighten too much, but we can check it on a fluoroscopy and the feeling, and now it's compressed. Then I remove this again. And we can disassemble the whole thing, isn't it? Mm-hmm. Yeah. We just turn this out. And then we, fully out. And then we have to bring this off here, Karl. Huh?
Yeah.
Yeah, that's the way. Now you see here, if we look from top, maybe we see the central position of our implant. We see the well-aligned plate to the shaft. Even if this is not fully perfect, the alignment here, so if it's a little bit more posterior, a little bit more anterior, I think it doesn't really matter. It's still there in contact to the bone, and it's still stable because this is a bicortical locking screw. Karl, anything else?
No, I think you explained it very well.
Do you have an option to measure the length of the anti-rotation screw?
So what we said is that the whole system is designed that the length of the anti-rotation screw is 3 millimeter above the bolt itself. So because it comes in one kit, the bolt is normally the same length as the anti-rotation screw. So we don't advise that it's too long, too longer, because then we maybe have got, because it's superior, then it cut through first. So it should be the same length as the bolt. But yes, you could measure the length of the anti-rotation screw, but normally it's the same length as the bolt. And regarding if it comes to rotational torsion stability, the longer you've got, so let's say if the neck is 110, the more they are diverted, so the longer the distance is between the tip of the anti-rotation screw and the bolt itself, so the more rotational stability you've got. So that means patients with a high offset automatically have got a higher torsion stability because the two implants are more divergent the longer they are. Okay, so then the focus race, the plan is that we enroll 112 patients. The primary objective of this study was still ongoing review is define the surgical and mechanical complications we've got. We follow the patients up for 3 months. If they have got any continuing complaint, then we add on 6 months and 12 months. We do, at this stage, we have got those hospitals are involved. They collecting patients together. At this stage, we have got 64 patients until now. So if it goes in this way, probably by July next year, we've got the 112 patients together. This system has been already released in some Asia-Pacific markets, especially Japan, and worldwide at this stage, there are more than 2,600 implants already been put in. So the numbers we're presenting here, that's a small number in comparison what has been implanted since Japan is doing since March this year. So we've got mainly females, and the main age is above 70. That's the main population group we're using it. If you look at the Gardner classification, we've got maybe 70% more or less stable fractures, so Gardner 1s and 2s. And if you look at the Powell classification, again, nearly 70% are type 1 and 2, but still, we've got 30% who have got a Powell's type 3 fracture. The 3 months follow-up at this stage, we have got 44 out of the 65 patients. We have got some adverse events. Out of the 64 patients, we had 3 times a massive collapse, where we changed it to a hemi or a total arthroplasty. All of the 3 patients, they were a little bit older, more than 73 years of age, and as it is, female, older, osteoporotic, and they all had a middle neck of femur fracture. In one case, it's a cut through, but a surgeon measured 95, the bolt, but the nurse gave it 110, and he didn't check on II, and that's how he just cut through into the hip joint. I think that would be a situation where we should not have used the FNS, but that's the complication we've got. And we've got 1 early breakage of the locking head screw, which has been then converted to a hemiarthroplasty. So only 1 implant failed in the way that we've got an implant breakage.
But this was a wrong indication, have I written here. So it was a trochanteric fracture. On one side it was lateral neck, but on the other side, if you look carefully to the X-ray, it went through the trochanteric region. This is one thing, and then the reduction was poor, I must say. It was done in our hospital. It was a poor reduction and wrong indication. We had after 3 weeks breakage of this locking head screw. Okay, so we continue with some interesting cases from Christoph now. Yeah, these are, let's say, problematic cases. You see here it's a 49-year-old male ski accident with this difficult fracture with a comminution posterior.
Question.
So intraoperative, after close reduction on the fracture table, we see this situation. And it was done in our hospital by one of my colleagues, and he realized that there's a big piece posterior displaced, so he decided not to open up, because he said, when I do an open approach, I come from anterior, I can anyhow not do anything sensible with this posterior piece. This, of course, could be discussed. So he just inserted the femoral neck system, and in this very unstable situation, he decided to use a 2-hole blade. That's the situation intraoperatively. Post-op, it looks like that. I mean, the position of the bolt is good. Also, the alignment of the plate, that's not the problem. You see, after 6 weeks, we have some shortening. After 3 months, a little bit more shortening. Patient went for full loading, so he's walking without crutches. And the last follow-up after 9 months, I think the fracture has united, and still this piece posterior, it's getting a little bit smaller. I think there's some resorption around the tip of this piece, but I don't know what really then happens in the next future with this situation. Now, just to show you how we can measure the collapse, so you can measure it here, because we know the bolt has a diameter of 10 millimeters, so we can measure the diameter of the bolt as to scale our measurement. So we have 13 millimeters, 8 millimeters. After 3 months, 5 millimeters. It means we have 8 millimeters collapse since the post-op picture. And even after 3 months, there was still a little bit ongoing collapse, but I think now it's a stable situation with this thing. So that's clear. That's a problematic case. We don't really know how he will be in 1 year or 2 years. Maybe he will get the total hip. Karl, what do you think about this case? What would you have done differently?
It's really the question. I think you probably can't improve the blood supply, because that's probably the major complication, because it's a huge posterior fragment. All the retinacular arteries, they may be disrupted. So I think what you did was probably the right thing to do. If he ends up having an avascular necrosis, I think then it's clear that he probably needs a conversion to a total hip. But I think what you did is great. There's only 1 centimeter of collapse. I think that's acceptable. I think you did a good job. I would have done probably the same.
Would have done the same. Of course, you can discuss to do a primary total hip. In this age group, I think we would not do for the moment. I think we would give the patient a chance that this can heal and that he can have a reasonable outcome. I think you do the same.
Absolutely.
Okay. Next case is this case. So it doesn't look so terrible, it's fracture, but on the axial fuse you see the displacement. Intraoperatively, the surgeon who did this, he looked to the fluoroscopy. AP view is okay. In the lateral view, he thought this is also okay. If he would have asked me, I would say no, that's not enough internally rotated the distal part, so we still have a malalignment. So put in the bolt, maybe a little bit high, a little bit too anterior, but the main problem is this malreduction. And if you see on the post-op picture, of course, you have a better quality on the post-op picture compared to the fluoroscopy. You see this malalignment, and you see it here, let's say more in detail. So what would have been the optimal position would have been something like that. So the head should be reduced in this position, or let's say the distal part to the head should have been reduced, something like that, and especially in the axial view, we would like to have this position. And I think if we would have this position, this would be perfect, and I'm sure the outcome would be good. Now, what happens here in this not really perfectly placed bolt in a not perfectly reduced fracture, after 6 weeks, we have still the same situation. And after 3 months, that's the last follow-up we have up to now, I think it looks healed. Patient has some remaining symptoms, of course, and we will see in the future what happens. If we look again here, measuring the dynamization, I mean the collapse, it's 8 millimeters. So I think that would be acceptable if this femoral head survives, which we don't know up to now. I think that might be okay. So the last case we show you is this case. So it's a failure case. You see it's an elderly female. She's polymorbid, had many different diagnoses and medications, including diabetes. She had this fall and this, let's say, a so-called stable neck fracture, medial neck fracture in a valgus impacted. So I would say it could be a good indication for head preservation. Now you see here the central wire is really nicely central. But reduction, again, for me, this is over reduced. So it's a little bit too in length because I would like to have this, let's say, in this position before I come with my fixation. Do you agree, Karl? If we see again here, that's, sorry, I have to go back again. So I think that's the position we have, and the better position would be here, in my opinion. Anyhow, this was fixed. You see the bolt here. The position of the bolt is perfect, also anti-rotational screw. And on the post-op picture, you see it here. And then what happens after 6 weeks and after 3 months? And the patient has pain. She could not really walk on this leg after these 3 months. So she came back as an emergency case on the emergency station because she could really not walk and had the pain. So a CT scan was done. Also, the situation was clear. I think it's not really necessary to have a CT scan because we anyhow have to convert it to a hemi or total hip arthroplasty. And this was done in this elderly lady with a hemi arthroplasty. Just again to see what happens here, we have here intraoperative 17 millimeters, post-op 15 millimeters. This is something we very often observe also with other implants. It's clear from the intraoperative situation to the early post-op situation. There is already a little bit of collapse, but then it went on down to nearly full collapse of the system and not healed fracture. So I hand over to Karl for the finish.
Okay. So far there are publications out there, mainly biomechanical publications, and they also presented in a numerous occasions in congresses and had some posters as well. So I think in summary what we can say regarding the femoral neck system, I think it convinced us biomechanically, if you look at all those data. It convinced us as a user because it's something small with a small diameter, small footprint. It's quite safe and quick. On average, it takes us maybe 20 to 30 minutes to put it in. You can do it minimal invasively, really, through a small incision, 3 centimeters, short surgical time, and a minimal blood loss. And it's convincing us because we've got now the opportunity to do a prospective study. It's not double-blind, but at least it's as a researcher, we can do something. It also convinced our staff because you've got one tray, everything is in one set. You don't need a system for anti-rotation screw for the DHS. So it's very easy handling, one system, straightforward. And at the end of the day, it convinced our patients because what we can see so far, the patients are complaining less pain. They stay a little bit less in the hospital. And locally, we've got less scar formation, in particular down the track if you at some stage you need any kind of a revision. So those is more or less the summary. And now we're open for maybe the next 10 minutes from questions from the auditorium and from online. Thank you very much. So we've got a question from the web. How do you do the after treatment regarding weight bearing?
Usually we go just for minimal weight bearing, 10 to 15 kilograms for the first 6 weeks. That's our normal after treatment. Maybe we could go for earlier loading, but usually these are younger patients. We preserve the head in a, let's say, younger patient, and usually they are able to walk on crutches. So if a patient is not really able to walk on crutches, I think that's not really the best case to go for a fixation.
Okay. The last question, just biomechanically, one guy is asking, comparing 3 screws versus the neck fix. So if you go into publication, I think it was published in Clinical Biomechanics, we tested 3 canalated screws versus a DHS with anti-rotation screws and the FNS. So what we can say, an angular stable implant like the DHS with an anti-rotation screw is as good as this minimal invasive system, and I think 300% better in a Powell's 3 fracture compared to 3 screws. So I think in Powell's 1, you're probably still safe to use 2 or 3 screws, but whatever has got a more vertical fracture line, but like Powell's 2 or 3, I think you should go for an angular stable implant. So I think we get here the sign, Christoph, that we should finish.
Yep.
Huh? I would like to thank you for the great
too.
demonstration and your cases. That was very, very interesting. And if you've got any question, I think you can see the email down there. Just send us an email and we'll try to answer as soon as we can. Thank you very much for your attention.
Thank you very much. Bye-bye.